Hi everyone. Today's video as promised is on Sialendoscopy. First of all, I'd like to thank Dr. Manju Madam who first introduced me to the world of Sialendoscopy. Now, when will you do a Sialendoscopy? Whenever you are suspecting a pathology in the salivary gland, that is when there is a salivary gland swelling, right? So, what are the causes of sialidinosis and in turn sialidenitis? Whenever there is any obstruction in the salivary duct system, it can result in a dilatation of the salivary duct system and later stagnation of secretions, and because of that sialidenitis. Okay, so that is the first thing. So what are the various causes of obstruction? The most important cause is, of course, salivary duct stones, right? And I already told you why it is more in submandibular salivary gland. Apart from that, you can have some mucus plug obstructing the salivary duct system, or it could be due to strictures. Okay, so these are the various obstructive causes. Now, what are the other causes? It could be due to radiation. So, radiation-induced sialidenitis is another cause, or it could be due to autoimmune causes. Okay, or like the Sjogren syndrome. And recurrent parotitis of childhood has to be suspected in a child who has got recurrent salivary gland swelling. So, what are the causes of sialidenitis? It could be due to obstruction, radiation-induced sialidenitis, juvenile recurrent parotitis, or autoimmune causes like the Sjogren syndrome, SLE, neoplasm, and granulomatous diseases. Now, what are the indications? First of all, there are some diagnostic indications like clinical suspicion of duct obstruction when you want to study the pathology of the salivary glands, or whenever there is recurrent salivary gland swelling which is not amenable to treatment. Okay. Now, what are the therapeutic indications? You can do it to remove the salivary duct stone, right? So, removal of stones is the first indication. Then, for removal of strictures, and of course, for irrigation of the channel and for imparting local steroids into the site. Okay, so these are the various therapeutic indications. Now, what are the advantages? It could be both diagnostic and therapeutic, and of course, it can be done in the same sitting itself, that is treatment and diagnosis. And it is less time consuming than surgery. It is less invasive with less complications and morbidity, and it can be done under local anesthesia if the patient is very cooperative. Now, what is the contraindication for the surgery? What happens when the salivary gland ductal system is getting obstructed? It can cause stagnation of secretions, and there could be an acute bacterial infection of the same, and that can result in acute sialidenitis, and because of that even abscess formation can also occur. So these are the contraindications for the procedure, that is acute sialidenitis and abscess formation of the gland. Along with that, when there is a previous failure for removal is also another contraindication that you have to remember. And when there is complete distal ductal obliteration, it will be difficult to negotiate a sialendoscope. So that is another contraindication. And if the size of stone is more than 10 mm, how can you remove it through a very small sialendoscope? So that is another contraindication. And for small ductal diameter, also it will be very difficult to negotiate the sialendoscope. So these are the various contraindications for sialendoscopy. Now, what are the types of sialendoscopes? Sialendoscope can be rigid like Mammootty's dance. It gives a crisp, clear optics, but the problem is that it can be traumatic to the lining, whereas flexible sialendoscopes are like Mohanlal's dance, very flexible and it is easily maneuverable. It is atraumatic to the ductal lining, and it can be used for distally positioned stone. And the only problem with this flexible endoscope is that it is having a short lifespan. Now, there are semi-rigid endoscopes available as well. What is the importance of semi-rigid endoscope? It combines the features of both rigid as well as flexible. So, the compact type of semi-rigid endoscope is the one which is more commonly used. It is therapeutic with working irrigation channel. Modular type is a diagnostic type of semi-rigid endoscope. Okay, now how will you do sialendoscopy? The first step in sialendoscopy is to find the punctum. And in case of submandibular salivary gland, the punctum is situated adjacent to the frenulum of tongue. The punctum is then dilated with the help of conical dilators or lacrimal probe. If the punctum is not found, what you have to do is you have to do a papillotomy and then enter the ductal system. And once you enter the ductal system, you have to keep it patent. For that, you have to do irrigation through the irrigation channel. Normal saline is used for irrigating, and after that you can remove the stone when you visualize it with the help of basket or graspers. Okay, with the help of basket or graspers you can remove the stone if it is less than 7 mm. If it is a large stone, you will have to downsize it. For that, what you can do is you can use balloons. Balloons may be used, or you can use laser. NDA laser, Homian laser and the excimer laser are the various types of laser which are used for salivary duct stone downsizing. Now, what are the other techniques that are used? You can use shock waves using extracorporeal shock wave lithotripsy, or you can use micro drills. Micro drills can be used to downsize the stones, and it can also cause dilatation along with stents and balloons. For intracorporeal lithotripsy, you use laser, as you can see here, and for extracorporeal lithotripsy, you are using shock waves. Now, what do you mean by combined approach? Here, what is happening is that endoscopy is used for assistance. So, it is an endoscopic assisted surgical technique, and it is indicated in case of proximal large stones, and it is done under general anesthesia, and endoscope is used to find the front wall of the stone. Then what you do is you use the transillumination effect of the stone to find the external location. After finding the external location, you put a mini incision of about 20 mm, and after that you dissect and find the duct. And after identification of the duct, what is done is stone is removed by splitting the duct, and then stent is placed intraorally at the ductal orifice. The stent is then flushed with corticosteroids. Why? Because you have to prevent restenosis, right? For that, you have to flush the stent with corticosteroids. Now, what are the post-op care measures to be taken? You have to ask the patient to take a soft, cold, bland diet. Then increased fluid intake is recommended. Wound massage is very necessary. Antibiotics have to be taken, and then stents have to be removed only after 2 to 4 weeks. So that's all for about sialendoscopy. I'll be coming with another important topic. Until then, goodbye.